Good evening, all. Alembic, the makers of cloth, welcomes you. It's a privilege to host such an eminent faculties and speakers for the day. We have with us Professor Mustafa, the Chairman, Department of ENT and HNS from Egypt. We have Dr. Shinal Kothari, the neurologist today, Dr. Isha Tuli, the ENT, and none other than Dr. Anirban Biswas with us, the neurologist for the day again. Handing over the proceedings to Dr. Ramesh Rohiwal, I'm sorry. And before taking any much time into it, I hand over to him. But before that, just 2 points. For better streaming experience, my request to all of you that you can put your video off, the delegates. And if you have any queries, request to put it in the chat box. Over to you, Dr. Ramesh Rohiwal.
Good evening, everybody. Good evening, Professor Mustafa. Good evening, Anirban sir. Welcome, Dr. Sheena and Dr. Isha. It's very nice to see you, Professor Mustafa. I've been your great fan.
Oh, thank you very much. It's a pleasure. It's a pleasure.
It's a great opportunity for people from all over India, those who are interested in neurology, to see you, hear from you, and get useful clinical points for day-to-day practice.
Thank you very much.
I request you to please go ahead and start sharing your screen and proceed. Give us a pulse of wisdom.
Oh, thank you very much. It's always a pleasure and an honor to be part of this wonderful series of meetings. And I would like to really thank Professor Biswas for giving me this opportunity, although I gave him quite a lot of trouble this time. So without any further ado, we are going to discuss some unusual aspects of migraine. As you know, migraine is quite common, and amongst migraineurs, there is quite a number who have vestibular symptoms, up to 40% in some studies. And these may be associated with their migrainous attack or completely separate, and this might cause some problems in the diagnosis. Among studies, we found that it is the commonest cause of episodic vertigo, especially in children. And it has a very strong genetic and familial predisposition. And many of the migraineurs do have a particular and a peculiar genetic predisposition. And this makes them very sensitive to some triggers. As you know, dietary triggers are very well known: hormonal imbalance, even emotional disturbances, physical exercise, and changes in the environment will lead to triggering of the trigeminal vascular system, trigeminal cervical complex, and certain changes in the cortex, with the cortical spreading the pressure of Leao, some vascular spasm, release of vasoactive peptides, and release of pro-inflammatory factors. All of these will lead to changes amongst different levels of the central nervous system, at the level of the cortex, at the level of the thalamus, the hypothalamus, and upper cervical nerves as well, and definitely all the trigeminal nuclei and all their connections. So numerous pathways are involved in migraine, and they are activated, and the CNS becomes oversensitized, and this makes different systems and the multisensory integrated roots prone to dysfunction. If you go back a little bit to our vestibular system, we have to understand that the vestibular system is not only the usual known peripheral vestibular system, or the semicircular canals, the utricle sacules, and so on and so forth. No, but it has a very distinct hierarchy which is distributed throughout the central nervous system. It consists of the lower level, which is the reflexive control of gaze and balance, the very well-known vestibulo-ocular, vestibulospinal reflexes. And then we go a little bit higher at the brainstem and cerebellar level. And at this level, we start to have the perception of sense motion, sensory motor control of voluntary movement and balance, where we want to go, how we are going to proceed. And this information is related to higher vestibular functions as well. And we found that these vestibular functions are not only related to balance, motion, and spatial discrimination, but they are involved as well in self-motion perception, self-consciousness, spatial navigation, memory, learning, movement correction, object recognition, and even numeric recognition. So the vestibular system is involved in so many higher functions which actually are going on in the background without our being conscious about these. These levels are interconnected with very complex central connections at the level of the vestibular thalamocortical pathway, from the dorsal tegmental nucleus to the nucleus reticularis pontis, via the cerebellum, and even via the basal ganglia. And at each of these levels, central integrations occur with transmission of spatial information, estimations of that direction, planning of our course, planning of our future actions, and as well information for spatial learning and spatial memory. As you can see, there is a very strong overlap between pathways of pain which are involved in the migrainous episode and the vestibular pathways in the brainstem, thalamic, hypothalamic, and cortical levels as well. So at each level, there is a very strong overlap between both pathways from the cortex, thalamus, hypothalamus, and upper cervical nerves, and the trigeminal nucleus, and the central pathways of the vestibular system. As you have seen, they are arranged with the same hierarchy, and there are very strong correlations between both. So we can infer that there must be some correlation between the trigeminal pathway and the migrainous attack and the central vestibular integrated processes. And there are reciprocal connections, and it was observed that trigeminal activation can induce nystagmus in migrainous patients without any vestibular stimulation as well. As a result of these integrations, there are disturbances with the migrainous attack in the functions of the vestibular system, with increased sensitivity of otolith and canal cues, enhanced responses to pain during vestibular stimulation, and even lower vestibular thresholds during photic stimulation. There are changes in the canal otolith integration in the brain, leading to abnormal sensory integration for spatial orientation and sensitization of self-motion perception due to sensitization at the level of the cerebellum.
চালিয়ে দিয়ে যেও তো এখানে আমার এই পাখাটাকে একটু পরে নিভিয়ে দিও
The different disturbances will lead to spontaneous vestibular activations with spontaneous attack of rotatory vertigo, vestibular drop attacks, autonomic syncopes, and these may also be triggered by head movement, by changing position, and by photic stimulation. Not only so, but additional symptoms occur, and as you are going to see, these additional symptoms are related to higher functions, not only to things related to the vestibule, like auditory symptoms, balance problems, autonomic dysfunction, which is part of the whole trigeminal autonomic pathway, visual changes with flashes of light, cervical pain, which is related again to the trigeminal cervical complex, and higher cognitive dysfunction. These higher cognitive dysfunctions include difficulty in concentration, memory problems, post-ictal fatigue, confusion, altered cognition, anxiety, panic attack, psychiatric problems, and abnormalities in self-motion perception. The patient does not know where he or she are going, how they are moving. There is spatial disorientation, and there is heightened self and visual motion sensitivity. And these patients during the attack will have a higher and lower threshold of motion intolerance and motion sickness. And not only so, they get higher central dysfunctions like, for example, paroxysmal perceptual dizziness and disorientations with failure of adaptation and habituation of postural control, persistent subjective vertigo and dizziness, hypersensitivity to motion stimuli, and difficulties with precision visual tasks. They cannot look at their mobile phone. They cannot do fine movement. For surgeons, for instance, they cannot perform properly their fine surgery as well. And it was found that vestibular migraine and its central dysfunction is a very strong problem in children, in affected children with sleep disturbances, problems in scholastic achievement, lack of concentration, even school phobia and hyperactivity, and periodic syndromes. You are all familiar with periodic vomiting, periodic gastric disturbance, and so on and so forth. Anxiety, depression, and panic attacks. All of these can be related to the migrainous overlap with the central vestibular connection. And these are actually new knowledge which was not realized at the time they were described. Two strange syndromes are also related to the higher vestibular function problems with migraine. These are Alice in Wonderland syndrome and Erlen syndrome. As you see, Alice in Wonderland syndrome simulates the problems mentioned in the story of Alice in Wonderland. And there are visual hallucinations, and the patients sometimes have distortions in their own size or the size of their surroundings, with sensation of fear, terror, disorientation, and even distortions in time perception. They think that time is either very long or very short, as if they are taking some drugs as well. And this is quite a serious thing. And most of these children and adolescents will progress to a classical migraine form, either vestibular or mixed vestibular and headache syndrome. Erlen syndrome as well is not very well recognized syndrome, but it is closely related to migraine and to the vestibular dysfunctions of migraine. Again, we have light sensitivity, reading problems. The patients are not able to read, and they are not able to cognize what they are reading as well. They have reading difficulties. Something like dyslexia, a little bit, problem with depth perception and environmental distortions and lack of problem. All these syndromes, as you see, are related to the very close interrelation between the vestibular system, higher vestibular function, and on the other side, the dysfunctions caused by the migrainous makeup of the patient and the very close overlap between the trigeminothalamic and the central connections of the vestibular system. Unfortunately, as you can see, these multiple symptoms are not easily documented investigation-wise, because most of our peripheral testing, the routine peripheral testing for the vestibular system, are usually normal, and many of these patients are stamped as psychogenic, or they have psychiatric problems, although psychiatric problems usually are associated with the vestibular system as a cause and effect. And many of the patients with vestibular dysfunction, with migraine, will manifest anxiety and depression as parts of their syndrome and not as a functional overlay. Sometimes higher vestibular functions will show us some disturbance, but as these are not in routine use, many of these patients are not properly diagnosed. In some patients, radiologically, on a properly performed MRI, we can see some gray matter reduction in the superior, middle, and inferior temporal gyri, which are the putative vestibular centers, and some atrophy in the thalamus as well, and hypothalamus in some of these patients. So we have to keep in mind that many of these patients with migraines, vertigo, or vestibular migraine can manifest with very strange manifestations of higher functions, cognitive functions, disturbances in spatial orientation, disturbances in recognition, in self-direction. And many of these are due to this very strong overlap between the migrance pathway and the connections between the trigeminal system, its central connections, and at the same levels as the central vestibular pathways. And we have to keep in mind that many of these patients should be properly diagnosed, because if you diagnose them properly, you should treat them like migrainous patients, not like only vertiginous patients, or worse, not like psychiatric cases as well. And we are still lacking proper central vestibular and definitely diagnostic steps for migraine as well. But once we can integrate these tests in our clinical practice, and keep in mind that many of these patients are not psychiatric, they are not only depressed, they are not only anxious, they do have a functional and an organic problem, we can properly diagnose them. And when they are properly diagnosed and treated, we can achieve extremely good results. Like patients with classic migraine, we can get very good results with dietary restrictions and with the properly directed medical treatment. And I thank you very much for your attention.
Thank you very much, Professor Mustafa. It was a really wonderful, lucid presentation covering all important aspects, those which are related with the vestibular migraine.
Thank you very much.
You have covered aptly everything which relates to this very complex problem which we have. We are facing, patients are facing in day-to-day practice. We see most of the patients have this type of varied presentations.
Thank you very much.
Thank you very much, Professor Mustafa. Now I'll invite Dr. Shinal to go ahead with her presentation. Dr. Shinal Kotari, she is a neurotologist. She is practicing as a neurotologist at Indore, and she has presented at many national neurological workshop and conferences her work. Please go ahead, Dr. Shinal.
So, good evening, everybody. Here I am going to give my small experience with the diagnostic challenges in vestibular migraine. What is not covered in the Bereni by the Bereni Society criteria. So this title is selected as to understand that even if the patient does not fit into the criteria set by Bereni Society, he may possibly be a case of vestibular migraine. So we should just remember what can be the features of atypical vestibular migraine. So in the second surgery, AD itself, Eritis of Cappadocia described about the attacks of migraine, what were associated with migraine headache, that is the heterocrania, the photophobia, that is tendency to avoid light, feel comfortable in dark, possible visual aura, that is a flying threads float in front of the eye, nausea, vomiting, and nystagmus. Then in 1999, the term vestibular migraine was introduced, and in 2012, the Bereni Society with International Headache Society laid the criteria. So where do we stand in 2021 is, like whenever we are dealing with a patient of vestibular migraine, then we must know that how we should proceed to avoid dilemma of diagnosis. In every case, wherever we try to work up, we have a subjective and objective evaluation. Subjective evaluation means the history and the symptoms. And in objective evaluation, the doctor does the clinical examination and investigations. Now, the Bereni Society has taken the subjective evaluation, that is the history and symptoms, into consideration for diagnosing the vestibular migraine. So in the history, we will talk about the history of childhood vertigo, the recurrent headaches, and the family history. The symptoms we will discuss, like what is the type of headache, what is the type of vertigo, the auditory symptoms, and at times they are accompanied with photophobia, phonophobia, osmophobia, visual aura. And clinicals, although they do not help much in the diagnosis of vestibular migraine, just to complete the list, the clinical tests and the investigations that do are this. So let us see what is the vestibular migraine in children criteria. So when we see in the Berenice Society criteria, we do not have an inclusion of anything like vestibular migraine in children. It basically talks about the adult vestibular migraine. So what is happening in children is, like, what can predispose children to vestibular migraine are the symptoms will be vertigo or disequilibrium, anxiety. The children are very anxious, and more anxious would be the parents of the child. So then we have to be like, there is a need to include vertigo as a symptom in addition to headache when we talk of vestibular migraine in children. Then often there is nystagmus, vomiting will be there, and also these children have suffer from recurring episodes for months or years, and otherwise the child is very healthy. Also, many of these children will later develop migraine, and in between, maybe for 8-10 years, they are absolutely normal. There is no problem. So there is a family history of migraine in the first degree relatives, and this is twofold increase in the compared with the controls. So prevalence of recurrent vertigo also is almost 2.8% higher in these children. So we would suggest that association of childhood migraine should be included when we talk of vestibular factors predisposing or atypical features in vestibular migraine. Then what are the headache criteria? The next comes is the headache criteria. So again, when we talk of Berenice Society, it says that there should be headache with at least 2 of the following 4 characteristics: the unilateral headache, pulsating quality, moderate to severe in intensity, aggravation by routine physical activity. Now let us see what are the criteria of migraine by the Berenice Society as far as headache is concerned. So in migraine, when we talk of vestibular migraine, it often misses the duration criteria for an aura as defined by International Headache Society. Accordingly, the headache should last for around 4 to 72 hours. But this does not happen so in vestibular migraine, because the headache may almost be absent, or it may last for a few seconds or maybe 2 hours or days. Then it says that there should be 5 attacks. But normally, nowadays, what we are seeing is that we are all so aware of the symptoms of the disease, so that modification can be suggested. Then also the vestibular migraine would miss on the temporal relation of the migraine to headache. What does this mean is that the vertigo can be preceded by the headache. Headache will come after vertigo, or the headache comes first and then will come the vertigo, or the headache may come much later than the vertigo phase. Or sometimes the vertigo may not be there only. The headache may not there only the vertigo would be the presentation. And the kind of headache that we get here is like very attenuated. That is, headache is much milder than what you get in a normal usual migraine. And as far if we follow the Berenice Society, they suggest moderate to severe pain intensity. So again, here the presentation becomes little atypical. Then when we talk of vertigo and headache may almost never occur only together. This is also known. So then you may have only one symptom at a time. Then laterality of the headache, when we say, so again the unilateral location is described, but when we talk of vestibular migraine, so many times we would get a bilateral representation of the headache. So when the headache is not there, then the diagnosis must be based on migrainous symptoms during the attack rather than the headache itself. So we suggest that the association with the temporal features of the headache should be considered apart while following the Berenice Society criteria. Then when we do not have headache, then there are certain other phenomena which represent apparent connection of vertigo with migraine. These criteria are like, all of us know what is photophobia. Then it could be phonophobia. Osmophobia is alteration in the sense of smell and visual or other auros. Then there may be certain symptoms which are although migrainous, but then they are not a part of the diagnostic criteria. This could be like osmophobia, we talked, the neuropsychiatric symptoms. These could be in the form of fatigue, emotional lability, or cognitive disturbances. There could be non-specific sensory changes. Then there could be autonomic symptoms like pallor, dry mouth, diaphoresis or diarrhea, or there could be some visual symptoms like blurry vision, visual snow, or palinopsia. So again, and Alice in Wonderland syndrome has already been nicely described by Professor Mustafa. So again, here we see some other features that should be concentrated on if you are not getting headache. Now, the clinical presentation in adults and the distinction from other diagnosis is either by the kind of vertigo or the kind of dizziness. But this again will be dependent on your history. So let us see what actually comes in the vertigo when we talk of history. So history could be, we will talk about the type of vertigo and the duration of vertigo. So the vestibular migraine patients typically report spontaneous or positional vertigo. Sometimes this spontaneous vertigo may take the form of a positional vertigo, and this is a typical spinning sensation. Sometimes we may get a sensation of translation or tilt or rocking, or sometimes swaying also, and or sometimes you could get an oscillopsy also. So then the duration when we talk, it is usually will be as long as the head position is maintained. Then we can have head motion intolerance. That is, the dizziness is provoked by any kind of head motion, and this will cause imbalance or illusionary motion or nausea or vomiting. So here again, we would suggest that the inclusion of non-vertiginous dizziness should be there, or then we should keep in mind, because as Barani Society, in this point is not there. So as a clinician, when we are seeing a case, we should remember that this can also point to a vestibular migraine. And then visual vertigo, this is again provoked by a visual movement, like when you are in a theater or you are in a marketplace or you are in a traffic. So all these things will again cause visual vertigo, and this is again pointing to vestibular migraine. Again, we say that there should be at least 5 attacks in this case also. So patient can present within 5 attacks also. Nausea and imbalance, although present, are very non-specific. So duration can be from seconds in about 10% to minutes or hours in 30% patients, and it may be up to several days or weeks also. So again, when we are taking a case of vestibular migraine, you must add the character of vertigo, nystagmus, and also include the non-vertiginous dizziness apart from counting the characters as mentioned in the Barani Society. Then migraine specific precipitants of vertigo. So if very specifically we see that the migraine attacks are precipitated by menstruation, deficient or irregular sleep, or excessive stress, specific foods such as matured cheese, red wine, glutamate, then some sensory stimuli, or when we miss a meal. So again, these points should also be considered when you are taking a vestibular migraine case, like you see in the migrainous headache. Sometimes weather changes can also precipitate a vestibular headache, or loud sounds, or when you are moving on an elevator. So any task that would require excessive head motion may precipitate a vestibular migraine. Then what can be the oral symptoms that are present? So like hearing loss, we do not discuss anything about hearing loss when we talk of criteria and the Barani Society as given by the Barani Society. But then in vestibular migraine, we can sometimes get a hearing loss. Also tinnitus is present, and then tinnitus is considered as a type of allodynia. Allodynia means altered sensory perception. And for this, the trigeminal cervical complex is responsible. So there is a central sensitization. So in this case, we should evaluate this. Now, oral symptoms are mild and transient. Usually they do not progress, they are bilateral. But sometimes when you get a fluctuating hearing loss, this is indicative of a Meniere's disease, and the migrainous features during the attack imply vestibular migraine. So here we see that both the disease can coexist. Now tinnitus comes in the form of oral pressure or a muffled hearing. And sometimes the patient will complain that I have a sensation of bubbling or pulsations or vibrations in the ear. Hearing loss is a regular accompaniment of Meniere's disease, but not of a vestibular migraine. And long history of episodic, if you have a long history of episodic vertigo with usual oral symptoms, which are mild and symmetrical hearing loss, then we would think in terms of vestibular migraine. But if it is a profound unilateral, low frequency sensory neural hearing loss, we should think in terms of Meniere's disease. And these cases should be subjected to trial of anti-migraine therapy. So inclusion of auditory symptom criteria should be taken up whenever we are discussing the vestibular migraine, in addition to what is discussed in the Barani Society criteria. Then a favorable response to anti-migraine drugs supports the suspicion of an underlying migraine mechanism. But can then this be taken as a definite confirmation for diagnosis? Let us see. So it can be a spontaneous improvement. It could be an effect of some additional drug that patient is taking, like anxiolytics or antidepressant, or it could be a simple placebo response. So you really have to judge whether this is due to your anti-migraine therapy or due to these three factors. So a role of drug therapy response should be considered. And this can, again, if it is there, we should add on to the Barani Society criteria. So patients with episodic vertigo accompanied by migrainous features should be offered a trial of migraine therapy if there are no contraindications. Then there are certain comorbid conditions, the psychological conditions. So these are the mood disorders. So mainly it comes in the form of anxiety. It could be depression also. So anxiety could be a sequelae or could be a predisposition to causation of migraine. So nausea and imbalance are frequent accompaniments again, but they are again non-specific. Then Alice in Wonderland syndrome has been already discussed. And again, the comorbidities can precipitate vertigo from seconds to several days. So association with comorbid conditions when they are associated, the patient may have an atypical presentation. Then the clinical and neurological findings in patients who have vestibular migraine, I'm just completing the list, but actually they are not very, very indicative of any kind of diagnostic confirmation for vestibular migraine. So about 10 to 20% of these patients have unilateral hypoexcitability on caloric testing. They have a direction. Some of them have directional preponderance, and some of them may show central oculomotor deficits. Vestibular migraine patients become more nauseous after caloric testing, almost 4 times the non-migraineurs. Okay, so these are the other features that we see. Nystagmus can be peripheral type of spontaneous or a central spontaneous or central positional or combined. So there is a varied presentation as far as nystagmus is concerned, and positional nystagmus will be present till the position is there. In BPPV, what will happen is it will fatigue out, but here it does not fatigue out. So what are the keys to diagnosis then? It is the repeated concurrence of migrainous symptoms and vertigo, sometimes the response to anti-migraine drugs, migraine-specific precipitants, the role of migraine-specific precipitants, and more like relief after rest. Almost every patient would tell you that once they take rest, they are relieved. So this is like the classification of the vestibular diseases that was given by Neuhauser H, and this was given in 2008. So before this Barani Society criteria came, this was what was followed. And then the Barani Society modified it to what we have presently. And then this new classification has come up, or the new criteria have come up, where this is a 4-layer framework for international classification of vestibular disorders. So what is linking is the symptoms and signs with syndromes, with disorders and diseases, and the mechanism causing these diseases. So the layer 1, as we can see here, talks about the symptoms and signs. Then in the layer 2, we will have the syndromes. So what symptoms and signs point to which kind of syndrome? And then in this syndrome, what type of diseases can be included and what are the causative factors for these diseases? So it is basically linking between all the four types, four factors that we take up whenever we diagnose a disease. Now, this classification actually is still, the work is on this classification. And only the layer 1, actually the symptom part has been written and published, from which I have taken this pic, and the science part is still in process, and then probably the layer 2, 3A and 3 will follow. So there are the 4 cardinal categories, and these depend on the vestibular symptoms: the vertigo, the dizziness, the visual vertigo, and the postural factors. So to sum up, there is no gold standard to say that yes, if this point is there, if this criteria is there, we say that the patient has vestibular migraine. We have to take up the atypical points along with the Barani Society criteria. You have to merge them before you take a diagnosis of vestibular migraine. Thank you so much.
Very nice presentation, Dr. Sinal. It has covered many aspects which are very common in our day-to-day practice. We are going to have more detailed discussion once we go for a panel discussion. Now I'd like to invite our next speaker, Dr. Isha Tuli. She is a professor and working at Delhi as a neurologist. And she has also presented her work at many forums, different forums. I request her to go ahead with the presentation.
Good evening, sir. I'm not able to share my presentation.
One moment. Is it okay now? Mr. Charlie, please look into the problem.
Yes, I'm looking into it, sir. Ma'am, if you can try again.
It's not happening. Share screen. Just give me a minute.
You have to log out and log in again, it seems. Yeah,
Yes.
it is there. It is there coming. Make it a full screen. Please go ahead.
Okay. Good evening, colleagues and friends. Today I'm going to share my experiences about some cases of vestibular migraine. I feel that diagnosing vestibular migraine is extremely challenging because it has varied presentations, and so it can not only be frustrating for the patient but also for the doctor. So today's agenda will include a discussion of a case of vestibular migraine that was diagnosed late due to a very casual history taking. The second case is that of vestibular migraine, which was diagnosed as a case of Meniere's disease. And the third case is a case of vestibular migraine, which later on progressed to also have 3PD. So my patient DK, who's a 35-year-old female who has presented recently with recurrent episodes of dizziness for around 2 years, for which she had consulted various doctors before being referred to our center. Her first attack was around 2 years ago, which had a sudden onset of dizziness for half an hour with nausea and vomiting for around the same period, due to which she was given antiemetics in the ER, after which she had some relief. She continued to have these episodes of dizziness of varying intensity and varying durations. A few times she also had a feeling of imbalance when she turned her head in a certain position, so for which a Dix-Hallpike test followed by an unsuccessful Epple's was done, and after that she was referred to our center. So here is a brief edited history at our center, and I would really like you to notice the history of migraine. Do you have migraine?
Ma'am, no, nobody diagnosed me as having migraine.
Why did you go to the orthopedic doctor?
Ma'am, I went to orthopedic doctor because I'm having pain in this neck again and again. It was a kind of throbbing sensation. So I went there. They did some kind of X-ray of my this side, and they found nothing abnormality in the X-ray.
How does the pain go away then?
Ma'am, I used to take some painkillers, and then ma'am, also when I'm having gastritis, I'm having pain in the neck. So I take this Pectop, and then I take some sleep, and after sleeping, I got relieved the pain.
She also thought she had cervical spondylosis, but her X-ray had come normal. So when we stitched together the old information and the new information, DK fulfilled all the criteria for vestibular migraine. And even though she had a history of migraine, she was unaware about it, and she described it as a neck pain. On examination, we didn't find anything remarkable, but we found here we can see a mild right upbeating spontaneous nystagmus, which was suppressed on fixation, and on SPP there was a tilt on both the sides. But these findings have been described for migraine, but they have also been described as non-specific. So for differentials, we ruled out BPPV because there was no vertigo or nystagmus on testing, and CRMs were ineffective. Vestibular neuritis because the disease was recurrent, it had varying duration. Meniere's disease because there were no oral symptoms, audiogram was normal, the attack duration was much longer. And TIA because despite having these recurrent episodes for 2 years, she did not have any neurological features. But something to be remembered is that migraine headache need not be present always, and we should never rush to a diagnosis, particularly in elderly patients with only 1 or 2 such episodes. They must be ruled out for stroke. So vestibular migraine does not have any biomarker. The diagnosis is based on clinical findings. The examination, imaging, and investigation can all be normal or can be non-specific. Regarding history, the patient cannot give a history of any headache. There might be a mild headache. The patient might forget to give a history of headache. It might be described as neck pain, as in our case, or there is always the ubiquitous gas or acidity in India, with which we find a large number of patients. The headache can occur before, during, or even after the attack. The vestibular symptoms include vertigo that may be spontaneous, it might be positional or head movement induced, it might be due to visual stimuli induced, it might be due to dizziness due to imbalance, which occurs more by head movement. So the importance of a good history in such cases cannot be stressed enough, and a thorough evaluation must be done for any patient which is coming to your clinic. But unfortunately, we don't always get such a patient whose complaints and examination neatly fit all the criteria of vestibular migraine. Often we get patients referred from elsewhere with a famous KCO syndrome, or they have a very confusing history. And if this is not muddy enough, vestibular migraine can be comorbid with other vestibular conditions as well. So a more in-depth evaluation is needed to come to a diagnosis and offer appropriate treatment. So my patient NT, she was referred to us in June this year. She gave a history of left ear block followed by difficulty in hearing 18 months ago, from which she partially recovered over the next few weeks. At the same time, she had a bout of severe spinning vertigo, and that recovered in 2 hours spontaneously. Subsequently, she had similar such episodes with completely asymptomatic periods in between. So she also gave a history of ringing sensation in 1 year. There was no history of any preceding upper respiratory infection, any trauma, and she did not give a history of migraine either. Her MRI was done at the initial place. That was unremarkable, and her audiogram was also done elsewhere, and that demonstrated a low frequency sensory neural hearing loss. But as you can see, this is not masked. So based on these features, she was thought to be of probably Meniere's, and she was started on beta histine. She had very minimal improvement. Symptoms continued, so another medicine was added, but she continued to have increasing frequency. And in the setting of poor hearing, she was offered intratympanic gentamicin injections because she was not getting any much relief. So she finally came to us where on further evaluation of her history, we found that she also complained of heaviness of head when she skipped meals or kept fasts. She had uneasiness in car journeys, and sometimes her episodes were triggered by head movement, especially bending, and sometimes her sense of imbalance lasted for 2 to 3 days. Her audiogram showed a low frequency sensory neural hearing loss, but this was during the interictal period, and she had normal caloric responses, and her V hit here we can see that the eye movement followed the head movement, and they aligned rather well. So based on this, we revised her diagnosis to be that of vestibular migraine. And then since starting propranolol, her DHI has improved remarkably. If we examine the criteria that has been put forth for vestibular migraine and Meniere's disease, we can see the attempts to distinguish the two diseases. For duration of attack for a vestibular migraine lasts for minutes to 72 hours, but for Meniere's disease, it is around 12 hours or approximately 24 hours in case of probable Meniere's. Another way we can differentiate between them is the type of hearing loss, which is low frequency sensory neural hearing loss in the affected 1 year, while in vestibular migraine, mild sensory neural hearing loss of both the years has been reported. So the question we may end up asking ourselves that in such cases, where can I fit in these symptoms, and what if there is any overlap? So she had some features of vestibular migraine and of Meniere's being spontaneous vertigo lasting less than 12 hours. She had some episodes of spontaneous vertigo, one-sided low frequency sensory neural hearing loss, fluctuating blocked ear, and she had some response to the treatment. Features fitting into the vestibular migraine were spontaneous imbalance, which lasted from few minutes to a few days, and this was also episodic. They were of moderate intensity. They were aggravated by activity, and she gave a history of migraine and motion sickness. She also had some overlapping features found in both migraine and Meniere's. That is, she had history of migraine as well as episodic unsteadiness, which makes us wonder if there is more to what meets the eye, if there is between these two entities. And therefore, our policy is always of revisiting the history and examination of the patient when the patient comes to us, and regular intervals also, and exclude vestibular migraine. And sometimes we give a therapeutic trial of anti-migraine drugs even before advising any aggressive procedure for Meniere's disease. Both Meniere's disease and migraine, they have overlapping symptoms such as spontaneous recurrent vertigo. The diagnosis is based only on patient's symptoms. There is no biological marker available. However, this overlap which has been observed, we find that patients of vestibular migraine have a Meniere's-like dizziness in 25 to 35% patients, There has also been observed a fluctuating hearing loss is seen in migraineurs, and it can be absent, particularly in early Meniere's disease. Oral symptoms can be found in vestibular migraine in up to 38% of the patient, and oral pressure can be mistaken for migraine headache and vice versa. Migraine is also more common in patients with Meniere's disease, and Meniere's is also more common with patients with migraine. So perhaps a migraine mania complex or an overlap syndrome exists that we are still in the process of covering. And this considerable overlap is particularly common in early course of both the diseases. And this was one of the reasons why initially the physicians were very reluctant to accept vestibular migraine as a separate, distinct entity. In his original treatise on Meniere's disease, Prosper Meniere did suggest a possible link between Meniere's disease and migraine symptoms. Supporting this argument, we see that there is a familial clustering of episodic vertigo, migraine, and Meniere's in close relatives, so there could be a common genetic link. Both diseases have common triggers. So why is this happening? One common hypothesis, as we know, is endolymphatic hydrops is the endpoint, final endpoint for Meniere's disease. And this happens due to an end organ damage, which happens due to a chronic hypoperfusion of the stria vascularis, which can happen due to a vasospasm of the spiral medullary artery. And we know that is supplied by the trigeminal nerve, which is a role of we also know about the role of trigeminal vascular system in the development of migraine. Another theory by some put forth by some authors is that there is an ion channel dysfunction in the brain as well as in the inner ear, where there is increase in extracellular potassium, and this causes cortical spreading depression of migraine and hydrops of Meniere's disease. Sarna et al. Have recently proposed a cochleovestibular migraine theory in which they say that migraine headaches lead to repeated neurogenic inflammation, and in an already hydropic inner ear, the inner ear cannot auto-regulate against these repeated attacks of inflammation, and probably this long-standing cochleovestibular migraine it manifests itself as Meniere's disease. So therefore, we must always revisit the history and always give a trial of anti-migraine drugs before attempting any destructive procedure for Meniere's disease, particularly in patients who have a poor response to therapy. This brings me to the last case of today's discussion. It is of a colleague who had intermittent spells of imbalance for around 3 months, and she described her first episode as a gradual onset vertigo with intense nausea, and she self-medicated herself, and she took rest in a dark room for that day, and she recovered, but she still had some unsteadiness. There was no headache, and these attacks continued, and they were triggered by stress or late night duties. And she gave a history of migraine in her 20s, for which she had never taken any prophylaxis. Her other features were unremarkable, so we diagnosed her as vestibular migraine, and we prescribed her on anti-vertiginous drugs, and after which she was really improved. However, in 2020, when the COVID pandemic hit us, she had a return of symptoms, and this time they were of increasing severity and frequency. So we tried to manage her with the co-therapy, and there was an improvement. However, despite this, she complained of a constant feeling of sway and imbalance, which reduced on resting. Despite this, she was uncomfortable in going out. She had a lot of anxiety. She had difficulty in taking ward rounds. And as the restrictions of the lockdown eased, she had difficulty going to the supermarket as well. She had difficulty in using electronics. So it has caused great deal of stress during online classes. And her examination was normal. She was not anxious or depressed, but DHI showed a mild handicap. So we revised her diagnosis from that of vestibular migraine to vestibular migraine with triple PD. With the consultant, with a psychiatrist, we gave her escitalopram and relaxation techniques. We encouraged gentle movement, and she has had good results now. So essentially, 3Ps clinch the diagnosis. There is a persistent non-vertiginous dizziness that really never goes away. The patient always says that there is some sway, some rocking, and it is increased by postural challenges such as more on standing up or on movement, and goes down on resting. And there is a heightened perceptual sensitivity to space motion stimuli. The patients are extremely uncomfortable when there is a lot of visual overload, such as busy environments, or even a patterned wallpaper or wall-to-wall carpeting can also make them extremely uncomfortable. And this is therefore now known as persistent postural perceptual dizziness, or 3PD or triple PD. This is not a new entity. In fact, in 1800s, it has been described when a single physician saw most of the cases of vertigo. But as in the earlier 20th century, the individual branches of neurology, otology, and psychiatry we became more specialized. This cause of vertigo, these patients got overlooked. And we'll find many such cases across various medical specialties such as globus or even irritable bowel syndrome. So this is a chronic functional disorder. Functionals mean there is a change in the function of an organ which is unrelated to any structural or cellular defects. And this has also been recently demonstrated on an functional MRI. So there is a problem, like I said, in the functioning of the nervous system, whether it is a postural control mechanism, whether it is a multisensory information processing, or in the cortical integration of spatial orientation or threat assessment. There is no structural deficit of the vestibular system, and there is no psychiatric cause where these patients were often initially dumped as. The exact pathophysiology of 3PD is not fully clear, but it is easier to explain to the patient that it is a software issue rather than a hardware issue. So briefly, what happens is after an acute postural threat, our body normally has some protective mechanisms, that is our posture and gait stiffens, and we rely more on visual cues and somatosensory inputs rather than vestibular inputs. But normally in patients, this we readapt. But in patients with triple PD, and it occurs more in patients who are anxious or have a neurotic personality, this cycle just continues, and they get trapped in this cycle of maladaptation, and a persistence of symptom occurs. So symptoms of 3PD can occur immediately after an acute attack, and the patient says he never really had a symptom-free period, as in vestibular neuritis. But commonly in vestibular migraine, we will find that there is a waxing waning episode, which then transformed into a persistence of the symptoms, which has a more stuttered course, or sometimes these will superimpose with the existing attack on vestibular migraine. Sometimes the patient can even forget that he had these old attacks and simply present to you directly with the symptoms of 3PD. So why did we diagnose 3PD for RR? Because we have to understand that this is a functional disorder. So no lab works, no scans or physical examination will show it. The diagnosis is made completely on ICD criteria, and all the boxes must check as they checked in the case of RR. She had difficulty with visual stimuli. It was precipitated by a prior attack, and the symptoms were significant distress, and it was not diagnosed by any other disorder. So all the criteria must be fulfilled in such patients, because we have to be rather inclusive of this criteria. We should understand that it can occur superimposed with other disease, and also we must not overdiagnose the patient. So there cannot be a waste basket diagnosis for us. We have to see that these criteria, the patient meets all these criteria. To tackle such a patient, so we come back to the neurologist, otologist, and a psychiatrist. A synergy between all the specialties is required, and therefore we can help restore balance in the patient's life. To summarize the key points for today, dig out the history. In a case of vestibular migraine, particularly, or a patient who's not responding to a treatment of vestibular of Meniere's disease, always revisit the history. Sometimes the type of sensory neural hearing loss can give you a pointer. A vestibular migraine prophylaxis should always be offered to patients of Meniere's disease before we offer them any destructive procedure. And 3PD should always be kept in our mind in any such patient, that we always have to be inclusive of this diagnosis. My deepest gratitude to all my patients who willingly came up with their history. I would also like to thank Anirban Vishwas sir for giving me an opportunity to speak in front of all of you. I would like to thank Dr. Preeti Lal, Dr. Kshitij Malik, Dr. Prateek Purwal, Kunzas, and Tanushree for helping me with this presentation. And thank you everyone for a patient listening.
Thank you very much, Dr. Isha. It was a very nice presentation. You have presented very different presentations, varied presentations of the cases which you have come across, and these are very common things which we see in our practice. Now I invite Professor Anirban Vishwas sir to go ahead with his talk. I don't think Anirban sir needs any introduction. He is Bhishma Pitama of neurotology in India. Anirban Vishwas sir, please go ahead.
Okay, let me first try to share this screen. But then the way you have introduced me, I'm feeling embarrassed, and it will take me quite some time to
That's your modesty.
to get this to swallow this. Anyway, let me try and see. Okay, so finally it has opened. I believe I can be heard also.
Yes, yes, you are audible, sir.
Okay. Let me go into the slideshow mode. Yeah, good. Okay. So I deal with the every part of vestibular migraine is messy. The messiest and the most complicated part is therapy. Why? The problem of vestibular migraine is that the ground reality about it is that there is absence of any definite treatment strategy for vestibular migraine. Why? Due to paucity of adequate and high quality randomized controlled trials on the therapy of vestibular migraine. And this is from a very recent paper, 2020 paper. Even now they're saying that there is a huge paucity of adequate and high-end randomized controlled trials on therapy of vestibular migraine. So until you have good high quality RCTs, how will you determine the therapy? Second is that the pathophysiology of vestibular migraine is not known with certainty. Current therapy is based on mere speculation that the pathophysiology of vestibular migraine is presumably the same as that of classical migraine. Now, this is mere speculation. We don't even know about it. And we presume that vestibular migraine is just the same as classical migraine. Is it true or is it wrong? Is it not true? We don't even know that. We don't even know whether vestibular migraine is an autonomous disorder with distinct pathophysiological features, or is it a sub-form of migraine that includes vestibular symptoms that we do not know for sure. And in case it is a sub-form of migraine, then what are the special features due to which some patients of migraine will show vestibular symptoms and other patients of migraine will not show vestibular symptoms. So until we know all of these things, how can you treat the patient? So treatment suggestions for vestibular migraine are extrapolated from knowledge gathered from clinical trials for classical migraine. So there is no good, dependable and reliable RCT or any workup on these things on how to treat vestibular migraine. Why? Because we don't even know the pathophysiology of the disease. We don't even know whether it's whether it's a separate disease or not. So with so many ifs and buts, don't expect that I can give you a very clean, clear-cut idea of therapy. This is where our science is, but then we'll try to make some sense of what is there. because we get a huge lot of vestibular migraine patients. And today it is believed that 1/3 of all patients that come to you with recurrent vertigo are actually vestibular migraine. So you, just because we do not have the right type of research, you cannot say that I will not treat it. So you'll have to treat it. So let us see the ground realities, and let us see what is the best that we can do, knowing fully well that our knowledge on this subject is not very clear now, and it is not evidence based. Now, what are the goals of treatment in vestibular migraine? Number one is aborting an acute attack, which is called rescue treatment. Second is prevention of vertigo episodes, or at least reduction in frequency or intensity of the vertigo attacks by more than 50%. And what is most important is with the minimum of medication or with no medication. How can we reduce the intensity and the frequency of vestibular migraine? And the criteria is that the frequency and intensity should come down by more than 50%. This is the international criteria that the treatment is successful or not. Then improving the quality of life of the patient. And lastly, treating the comorbidities for vestibular migraine. So these are our 4 goals of treatment: aborting an acute attack, which is called rescue treatment; prevention of vertigo episodes, or at least reducing the frequency and intensity of the attacks by more than 50%, and that too, most importantly, with minimum medication or with no medication; improving quality of life and treating the comorbidities. Now, treatment of vestibular migraine, it requires a multi-pronged approach, 5 ways. One is aborting acute attacks of vestibular migraine. Secondly is lifestyle modification plus trigger avoidance plus physical exercise. These are the non-pharmacological ways. Then the pharmacological prophylaxis of vestibular migraine. Then there are certain nutraceuticals in the prophylaxis of vestibular migraine. And lastly, the treatment of comorbidities. So when you are discussing treatment of or management of vestibular migraine, we have to touch upon these 5 aspects. Let us go through them one by one. Most important is lifestyle modification plus trigger avoidance plus physical exercises. If you are very strong with this, with the lifestyle modification, trigger avoidance, and physical exercises, then you may not have to use any medicines at all. So our primary attempt should be to stick to lifestyle modification, trigger avoidance, and physical therapy. Why? Because if by this we can control the vestibular migraine, then we don't have to use the drugs, all of which come with a huge baggage of adverse effects. These drugs are either calcium channel blockers, or they're anti-epileptic drugs, or these are psychotropic drugs. So they come with a huge baggage of side effects. So we have to try and see how can we treat it without medication. And if we have to use medication, then with a minimum of medication. So that should be our goal in treating a patient with vestibular migraine. Now, let's come to non-pharmacological treatment, that means without using drugs, and they're extremely effective. Number one is lifestyle modification, and that consists of regulated, relaxed lifestyle, proper diet, avoiding foods which are commonly known to trigger migraine, adequate sleep and rest. Adequate, not excessive. If you are having excessive sleep, then that also can trigger migraine. So remember the word, the right amount of sleep. That means about 7.5 hours of sleep. Then avoidance of triggers like exposure to sun, late night partying, etc. Now, with the younger generation, this late night partying and all, this is extremely common. And not only late night partying, they all work for multinational companies, and where they are used to working till very late nights, and that is one of the strongest triggers for migraine. Then moderate physical exercises, especially vestibular physiotherapy, that helps in a big way. We'll come to that, how physical therapy and especially vestibular physiotherapy can help in migraine. Here again, the same thing, moderate physical exercise. Excessive of physical exercise will again trigger migraine. So there has to be a balanced amount of exercise. And lastly, stress management, reduction of mental anxiety and tension. So these are the lifestyle modifications that is essential in any patient of migraine. And even if you are giving drugs to the patient of migraine, any medicine that you are giving, you will have to ensure that these lifestyle modifications are extremely well followed. Then we have the second thing is the avoidance of food triggers which are known to trigger migraine. Some physical therapy exercises, this one. Then use of protective gear to lessen the photo and phonophobia. And lastly, neuromodulation. It is a new type of therapy. We will come to it in case time permits. If Dr. Ramesh Royal allows us the time, then we will also discuss a bit about neuromodulation. So these are the different types of non-pharmacological therapies: lifestyle modification, avoidance of foods which are known to trigger migraine, physical therapy, that is exercises, use of protective gear to lessen photo and phonophobia, and neuromodulation. Now, non-pharmacological, we have covered lifestyle modification. Now let's come to avoidance of foods known to trigger migraine. A migraine patient is expected to avoid frozen, canned, or pre-packaged foods, chocolates, coffee with cocoa, cold drinks that contain caffeine, cheese, Chinese foods and potato chips which contain monosodium glutamate, pickles or preserves, any fermented products, red wine, peanuts, breads and other products that have yeast, processed meats, smoked fish, smoked meat products like salami, ham, sausages. The list is huge. Especially which is now not new, which is known but not so much highlighted, is that foods that contain histamine or increase histamine levels in the blood, they have to be avoided in all migraine patients. So foods that contain high histamine like tofu, soya sauce, foods with vinegar, mushroom, overripe fruits, or fruits that cause histamine to be released from other foods like kiwi, lemon, lime, pineapple, plums, papaya, some beans and pulses and tomatoes, they have to be avoided. So anything that releases histamine or foods that will allow histamine to be released from other fruits, because histamine is dangerous in patients of migraine. And so remember that when you're treating a patient of migraine, be careful when you are using beta histine, because in case we do not know, but in case beta histine does actually increase histamine levels, be aware of it and don't use beta histine in patients of migraine. Then physical therapy, non-pharmacological protective measures, and neuromodulation. So avoidance of foods known to trigger migraine, these are the ones. But then see, I've given us such a huge list that you will think that what will my migraine patient have? What will my migraine patient eat? Well, there is a huge yes list also, and this is the yes list. So there are a lot of drugs, there are a lot of foods which the patient can have, and if you go to, there are different websites. One is known as Migraine Cookery, and then there is My Migraine Brain. So there are different types of websites where they have special books for preparing food for migraine patients and what migraine patients can have. These are the list of foods that migraine patients can have. Then the non-pharmacological treatment, the last part is not the last part, the second last part is vestibular exercises. Physical therapy, especially vestibular exercises. See, it has been found that vestibular exercises, not only general physical therapy, vestibular exercises, they help to achieve habituation to vestibular motion stimuli for visually induced symptoms, space motion discomfort and all, they are reduced by that, and it ameliorates intolerance to moving visuals. All migraine patients and vestibular migraine patients, they have an intolerance to moving visuals. You show them a moving things, then they start feeling intolerance, and that leads to headache. And vestibular exercises achieves habituation to visual motion stimuli, and that helps migraine patients in a very, very big way. So vestibular exercises have got a big role. Vestibular exercises, it helps to correct postural stability, which is very commonly jeopardized in patients of vestibular migraine. Vestibular exercises restores confidence, attenuates headaches too. I'll show in the next slide that by doing just vestibular exercises, not only does the vestibular symptoms improve, but also headaches come down. It is strange, but there are studies which have shown that just by allowing the patient to do vestibular exercises, the headaches of migraine patients can also be reduced. There are peer-reviewed excellent RCTs on this. Then vestibular exercises are also effective as a standalone therapy and also in combination with pharmacotherapy for vestibular migraine. So if you are giving the patient drugs for vestibular migraine, combine vestibular exercises with it and the results will be much, much better. See, all references are given over here. So it has been found, it has been there in this. This is the reference, Sugai et al. They have shown that just avoidance of caffeine stopped vestibular migraine in 14% patients. Just avoidance of caffeine, that stopped vestibular migraine in 14% of patients. In our experience in our clinic at Vertigo and Deafness Clinic, in the last 5 years, we have found that lifestyle modification, vestibular physiotherapy, and avoidance of food triggers for 3 months stopped vestibular migraine attacks in as much as 53% of 486 patients in whom we had not given any drug. And there was more than 50% improvement in 64% patients with just combination of lifestyle modification, vestibular physiotherapy, and avoidance of food triggers. So what I mean to say is that this non-pharmacological therapy has got a very big role to play and never undermine the role of vestibular of non-pharmacological vestibular exercises. This is the article by Sugaya. You can refer to it, and it has been shown that there is improvement in dizziness followed by vestibular rehabilitation, and it was associated with improvement also. It was also associated with improvement of headaches, more prominently in vestibular migraine patients compared with comorbid tension type headaches. So in patients who did not have vestibular symptoms, only had headaches, in those patients also the vestibular exercises reduced the incidence of headaches. And in patients of vestibular migraine, both the headaches reduced as well as the vestibular symptoms reduced. So this is the beauty of this study. And that is why we stress upon vestibular exercises in patients of vestibular migraine. So vestibular migraine exercises contributed to improvement of headaches, which is the most surprising thing, both in patients of vestibular migraine and also in patients of dizziness and tension type headaches. It caused an improvement of dizziness, and it caused an improvement of psychological factors, which has been calculated in this study by HIT6, DHI, and the hospital anxiety depression score. So see, this is a extremely well conducted level A study which has shown this. So the non-pharmacological treatment for the photophobia and phonophobia, we ask the patients to use the FL41 optical tint indoor sunglasses and also the Vibes earplugs that reduces the sound. So you can go into the website and get the details of this. These are all available in India also. Now, coming to the pharmacological treatment of vestibular migraine. Now, indications, the medications for where do we use medications for vestibular migraine? We use medications for 3 things: aborting an acute episode of vertigo or headache in vestibular migraine, which is called event management or rescue treatment. Then we use medications for prophylaxis of vestibular migraine, and we use medication for treating the comorbidities of vestibular migraine. So there are 3 places where you can use drugs: aborting an acute attack, preventing vestibular migraine attacks, the frequency and intensity of the attacks, and for treating the comorbidities. So these are the 3 ways. First, we start with treatment of an acute migraine episode, which is also called abortive therapy, event management, or rescue treatment. Now, the drugs for aborting an attack of vestibular migraine, where whatever drug you are giving, remember 3 things. It has to be administered at the onset of the attack. Don't wait till the attack has fully started. Give the drug immediately at the onset of the attack for it to be effective. Remember that single dose usually suffices and it must be discontinued immediately after the relief. So if you have given the patient something like prochlorperazine or meclizine, then use it for one dose only. After the vertigo subsides, don't go on continuing with the meclizine or the cinarizine or the prochlorperazine. So single drug suffices. If the patient has got headache, one dose of naproxen or ibuprofen should suffice. You don't need to continue giving the drug. So always know that for aborting an acute attack, a single dose usually suffices. And three is that the same medications are used as for aborting any attack of vertigo or from any cause, whether it's due to migraine or it is due to vestibular neuritis or it is due to Meniere's disease. The same drugs are used. What are the same drugs? Prochlorperazine or dimenhydrinate or meclizine or cinarizine. So these are the drugs that are used to give to for aborting an attack of acute vertigo in vestibular migraine. In our clinic, what do we do? See, if the patients are serious, then in our clinic, we ask the patient to use this combo. 2 tablets of dimenhydrinate, which is marketed in the name of Gravol, 50 milligrams to swallow and then suck. 1 tablet of clonazepam, I'll tell you why clonazepam, and 1 tablet of prochlorperazine, 5 milligram. If the vertigo and vomiting persists after 30 minutes, then injection of prochlorperazine 12.5 milligrams IM stat with 1 tablet of promethazine 25 milligram. If headache, then we use 1 tablet of naproxen 500 milligram or ibuprofen 400 milligrams plus 1 tablet of zolmitriptan 5 milligram or nasal spray if there is vomiting. So this is what we follow in our clinic, but this is for a severe attack. Otherwise, just 1 tablet of naproxen for the headache or ibuprofen for the headache or 1 tablet of dimenhydrinate suffices. But if it's a severe attack, then this is what we need. But we usually try to combine clonazepam with it. Why clonazepam? I'll tell you now. The treatment for an acute episode of vestibular migraine, the abortive therapy and the rescue treatment, the recommended drug options are these. You can use any of them. Benzodiazepines like clonazepam or diazepam, antihistaminics like meclizine, cinarizine, dimenhydrinate, antiemetics like promethazine or prochlorperazine, ondansetron or scopolamine, analgesics in case of any concomitant headache, naproxen or ibuprofen, triptans like rizatriptan and zolmitriptan, and corticosteroids. It is only in cases of status vestibular migraine where the vestibular migraine continues for more than 3 days. That is known as status vestibular migraine. I have had 2-3 patients only, and there we have used corticosteroids with wonderful results. Otherwise, don't use a corticosteroid. So these are the different options available, and the underlined ones are the ones that are safe in children. In children, you can use clonazepam, dimenhydrinate, prochlorperazine, or zolmitriptan. Or for the headache, you can use ibuprofen. These are the only ones that are recommended that can be given safely in children, depending upon the age. The best drug for acute episode of vestibular migraine is benzodiazepine. Why? Because of these reasons. It is agonistic to inhibitory neurotransmitter GABA. It increases the efficiency of GABAergic synaptic inhibition. GABA, is a inhibitory neurotransmitter, and it decreases hyperexcitability of the brain and decreases neurotransmission. Hyperexcitability of the brain and increased neurotransmission is the pathology behind migraine, and so GABA reduces that. GABA inhibits that, and benzodiazepine is an agonistic to the neurotransmitter GABA. Then the benzodiazepine, that is clonazepam, decreases the cortical spreading depression, which is the cause of migraine. It facilitates the GABA activated cholinergic channels, causing hyperpolarization and thus decreased firing rate of the first and second order neurons of the central vestibular pathways. It enhances the pain threshold and therefore reduces the headache, if any. It is a labyrinthine sedative and hence inhibits the vestibular nuclei and hence reduces vertigo. It is also an anxiolytic and reduces the concomitant anxiety. So you see, benzodiazepine, that is clonazepam mainly, helps in so many ways. So whenever you're treating a patient of acute episode of vestibular migraine, whatever drug you use, add clonazepam to it at a low dose. Treatment for acute vestibular migraine episode, triptans. You will all ask that since you can use triptans in acute headaches, why can't we use triptans over here? Triptans have not been found to be very effective. And if there are headaches, you can use sumatriptan, rizatriptan, or zolmitriptan. But in vestibular migraine without headaches, there are RCTs, randomized control trials available only with rizatriptan and zolmitriptan. But these are not very large studies. And with rizatriptan 10 milligrams, it has been found that 15 out of 25 patients improved in motion sickness only, but no improved in more complex vestibular symptoms. Zolmitriptan 38% improved versus 22% of placebo. So these are the only two triptans which have been tried through RCTs. There are randomized controlled studies only for rizatriptan and zolmitriptan, not for any of the others. And there also, they have not been found to be very effective. But you can use zolmitriptan. Then we come to prophylactic pharmacotherapy of vestibular migraine. When to use prophylactic pharmacotherapy? Indications for prophylactic pharmacotherapy are there are 2 or more attacks per month, or disability lasting 3 or more days per month, or there is failure of or contraindication to acute treatment. That means you cannot use any of the acute treatment drugs. Or using abortive treatment is required for more than once a week, because those drugs which we use for abortive treatment is best not used very regularly. So these are the only conditions where you can use prophylactic therapy. Then avoidance of known migraine triggers. Whenever you are using pharmacotherapy, for prophylactic pharmacotherapy, you have to know that avoidance of known migraine triggers must be there. Lifestyle modification must be followed diligently, and the vestibular exercises have to be done. Prophylactic pharmacotherapy is instituted only when adequate trials at least 3 months with lifestyle modifications, exercises, and trigger awareness fail to contain symptoms. Otherwise, don't jump into pharmacotherapy for prophylactic management immediately. First, try out the non-pharmacological therapy for 3 months. Then, if you find that it is not adequately helping, only then you can go in for drug therapy. Prophylactic pharmacotherapy of migraine. These are the different types of drugs used. Beta blockers, propranolol, metoprolol. Calcium channel blockers like flunarizine and verapamil. Antiepileptic drugs like topiramate, divalproex sodium, or lamotrigine. Tricyclic antidepressants like amitriptyline and nortriptyline. Selective serotonin, norepinephrine inhibitors, SSRIs and SSNRIs. Sertraline, venlafaxine and desvenlafaxine. Nutraceuticals like butterbar extract, feverfew, and other agents like acetazolamide, magnesium, cyproheptadine, and pizotifen. The underlying drugs are safe in children if prescribed in the correct dosage. That means in children you will have to limit yourself only to propranolol or flunarizine or topiramate. But magnesium, cyproheptadine, and pizotifen can be used in children. So we have got so many drugs. So how do you choose a drug? On the basis of what? In a patient of vestibular migraine has come to you, how do you decide which drug to use and how many drugs to use? There is so much of options available. So how do you decide on the drug therapy? Skip this. So prophylactic pharmacotherapy of vestibular migraine, which drug and how many drugs? See, there are certain principles. No studies show superiority of any one group of anti-migraine drugs over another group. Don't think that anti-epileptic drugs are in any way better than, say, beta blockers, or that calcium channel blockers are in any way better than beta blockers. So no studies have shown that there is any superiority of one group of anti-migraine drugs over another. So do not go by that this drug is a better drug. The drugs are selected on a completely different parameters. We'll come to that. choice of drugs is usually based on comorbid condition. That means whether there is hypertension, if there is anxiety, asthma, depression, PCOD, glaucoma, on the patient profile. That is, if the patient is obese, underweight, if the patient is in childbearing age, on these conditions, we determine which drug to use. As I said, no group of drugs is superior than another group of drugs. Then drug therapy, that means dosage and number of drugs to be titrated on response to the chosen therapy and the tolerance or adverse effects on that particular patient. And poor response to one drug does not mean that diagnosis is wrong. Drugs from another group must be tried. Supposing a patient of vestibular migraine has come to you and they have started topiramate, and you find that if the patient is not responding, don't think that your diagnosis is wrong. Then try with either a calcium channel blocker or a beta blocker, or with a or with an SSRI. So that is how these things work. Everything which I am showing you is reference. All the references are given here. Principles for prophylactic therapy of vestibular migraine. Again, combining two drugs from the same group is always to be avoided. Don't use two anti-epileptic drugs. Don't use topiramate with divalproex sodium. Don't use two beta blockers like flunarizine and veripramil. So don't use two drugs from the same group. Then combining two drugs from two groups does not necessarily improve treatment. It has been found that effect of topiramate with propranolol is the same as that of topiramate alone or propranolol alone. So combining topiramate with propranolol is not going to give you any better result. Best is to start with one drug only at a lower dose and then slowly titrate the dose as per patient response. And patients may respond to one drug, but after some time the efficacy is found to decrease in spite of increasing dosage. Change to another group is usually beneficial in such cases. So these are the principles that you have to follow. See, this is just one study to show you that propranolol and venlafaxine for vestibular migraine prophylaxis, a randomized cortical controlled trial. It showed that venlafaxine and propranolol show equal effectiveness as prophylactic drugs for ameliorating vertiginous symptoms in vestibular migraine. However, venlafaxine may be superior to propranolol in ameliorating depressive symptoms. So combining venlafaxine and propranolol did not give any extra result. You can use either propranolol or venlafaxine. If the patient has got some psychogenic symptoms also like anxiety, etc., then of course giving venlafaxine would be a better choice than propranolol. So don't try to combine drugs and think that you will be getting a better result. Now, drug selection based on patient profile. How do you select the drug? If the patient is obese, then you should avoid flunarizine or propranolol or the tricyclic antidepressants like amitriptyline. In that case, in an obese patient, select topiramate. If the patient is skin and leany, avoid topiramate as it will decrease body weight. And in that case, you can select something like amitriptyline or flunarizine. If the patient has got dementia, many patients of vestibular migraine also have dementia if you take a history. You will, in that case, avoid topiramate and try any of the other drugs. If the patient has got glaucoma, don't use topiramate because topiramate can increase glaucoma. Use some other drug. If the patient has got any hypotension or bradycardia, avoid propranolol and use something else. If the patient has got mental depression, avoid propranolol and flunarizine. You can use a drug like venlafaxine or desvenlafaxine. Female in childbearing group, avoid divalproex sodium and if possible also topiramate. You can select a drug like propranolol or flunarizine. If there is a hepatic disorder, avoid divalproex sodium or sodium valproate, and you can select a drug like topiramate or lamotrigine. If patient is on other drugs for other diseases, then drug interaction must be checked because most of the drugs interact with a lot of other drugs also. So drug interaction must be checked before any migraine prophylactic drug is given, and you can check it from www.drugs.com. So you can check the drug interaction, ask the patient what drug the patient is taking, check drug interaction from www.drugs.com and then prescribe the drug. So contraindication is specific age groups. But topiramate is contraindicated in patients of glaucoma, in patients of kidney stone, in patients of chronic kidney disease, in memory loss, and in depression. Divalproex sodium is contraindicated in young females, high ammonium levels in blood, liver disorders, and in depression. Flunarizine is best avoided in obese patients, in patients of Parkinson's disease, in patients with extrapyramidal disorders, and in patients of depression. So you see, you select the drugs on this. The causes of failure or non-compliance to therapy. When you prescribe a drug, you'll find that in many patients, the patient is not compliant with it. Why? Why is the patient not compliant with it? Improper dosage or causing intolerance, persistence of the disease. It means that the dose needs to be titrated or escalated or reduced in smaller steps. Do it in smaller steps. So if there is intolerance or persistence of the disease, titrate the dose. Most of the drugs are pretty costly. So try with a cheaper drug. There can be adverse effects like weight gain, anorexia, palpitation, depression, drowsiness, constipation, and dry mouth. So you have to then change the drug. There can be lifestyle changes and avoidance of triggers not being followed. So always counsel the patient, whatever drug you give, lifestyle changes, avoidance of triggers, and exercises must be there along with the drug. So if these are not there, then that can cause a failure of therapy. And so counsel the patient again. Addressing comorbidities, the mood disorders, they have to be treated by this or MARD means migraine anxiety related disorder. So it will require psychiatric or psychological referral, counseling, and antidepressant therapy. If there is persistent interictal dizziness, additional space motion discomfort, a lot of these vestibular migraine patients have it, they have to undergo vestibular rehabilitation therapy, especially the eye exercises. If there is motion sickness, then pre-medication with meclizine or dimenhydrinate or benzodiazepines before undertaking a journey. Treatment of MARD, depending upon the symptoms, you select the drug. We are not going into the details of that, lack of time. Adjuvant therapies or nutraceuticals, these are the ones that can be used: riboflavin, magnesium, butterworth extract, coenzyme 10, Q10, and vitamin D. These are the ones that have been found. Out of them, the best is magnesium, 600 milligrams per day, which you can definitely prescribe to your patients of vestibular migraine. Non-pharma, then we come to the last part, that is neuromodulation. It has been proven to be effective. Neuromodulation has been proven to be effective in classical migraine. This is one form of non-pharmacological therapy where we are giving an electrical stimulation to the patient, and not only an electrical stimulation, we are causing a neuromodulation. And it has been found to be very effective in classical migraine. So if it is effective in classical migraine, so why should we not try it for vestibular migraine also? Neuromodulation is the functional modification of neural circuits within the non-pharmacological stimuli delivered non-invasively or by implanted devices. There are implanted devices also, or some devices you can give present from outside also. Devices used for neuromodulation use electrical current or magnetic fields or caloric stimulation to modulate signaling activity in the brain. It is used both for rescue therapy as well as for prophylactic therapy in classical migraine. Though not yet considered as first-line treatment, some of these non-invasive forms of neuromodulation have been approved by FDA for classical migraine and for cluster headaches. So these are approved products. So non-invasive neuromodulation therapies for migraine and cluster headaches are a practical and a very safe alternative to pharmacologies. What are the different types of neuromodulation available? The proven efficacy in classical migraine, it has got a proven efficacy in classical migraine. So why not try it for vestibular migraine also? These are the different processes available: transcranial magnetic stimulation, deep brain stimulation, supraorbital nerve stimulation, sphenopalatine ganglion stimulation, occipital nerve stimulation, and vagal nerve stimulation. They have been successfully tried in classical migraine and in cluster headaches. Other forms are neuromodulation by repeated caloric stimulation has been tried in migraine, but no reports are available in vestibular migraine. External trigeminal nerve stimulation It is called E10s. It is found effective in rescue treatment of vestibular migraine. So these are, if this E10s, it is another very good thing. So if classical migraine and vestibular migraine share the same pathomechanism, and if the same drugs work for both classical migraine and vestibular migraine, then neuromodulation should also work for vestibular migraine too. So let us try it out. Let us work in conjunction with a neurology colleague. And these instruments, I'll show you the instrument, they don't cost much. Anything between 10,000 rupees to 30,000 rupees. See, these are the different devices available. Transcranial stimulation for by spring TMS. This is spring TMS. Vagal nerve stimulation by gamma core or electrocore. Stimulation in left and right supraorbital or supratrochlear nerves by Kefali. This is Kefali. This has been used. This is the only one that has been used in vestibular migraine with very good outcome. And this is the reference. Bay has used it, and it is published in the Journal of Neurological Science in January 2020. This is called Kefali. This has been used, found to have very good effect in vestibular migraine. Peripheral nerve stimulation by nervomigration. These are the different types of devices that are used. Now, what is the protocol that we follow in our clinic? This will take a bit of time, so I am skipping in this portion. We follow this, and we have got excellent results in vestibular migraine. And this is our results, just to show that, basically to show that what excellent work we do. Forget it. But then the point is that this is how we do, and we have got very good results using that protocol that we follow. Now, let us not forget, this is the last slide, that regular follow-up, re-evaluation of outcome and dose titration is mandatory at 3-month intervals in all patients of migraine. And your goal should be more than 50% reduction in attacks. It is a reasonable goal. Patient to maintain a very detailed diary of vestibular and headache events. Migraine and vestibular disease, especially Meniere's disease, can coexist. I believe Dr. Isha has stressed on it and driven it home very, very well. Comorbidities to be paid extra attention. Detailed history taking is essential. This, I believe, also Isha has stressed very well. We must support randomized clinical trials in vestibular migraine for better treatment options for our future patients. Not much of randomized classical clinical trials. Not much, not at all. RCTs are available for vestibular migraine. And newer treatment modalities like neuromodulation by non-pharmacologic modalities must be tried in vestibular migraine. So thank you.
Thank you very much. Thank you very much, Anirban sir.
Okay.
It was a very nice presentation covering very minute aspects related to pharmacotherapy and neuromodulation, which you have told just now is something very new, and definitely it warrants to be tried. I'll request our esteemed panelists to go for a few questions, and I think we'll start with Professor Badar. What are the criteria?
Sir may not be available because sir had come in between a surgery. He had left the surgery and come, and so if he's there, fine. He may not be there also.
I'll just check. No, I don't think he's not there.
He isn't here, sir.
He isn't there.
Yeah.
Achha, okay. Let us see how much we can do.
We'll start with you only, sir. I will like to ask your opinion about what are the criteria which you decide clinically and in history so that you start a prophylaxis for a migraine patient.
This is difficult to answer, but see, the point is, before starting prophylactic drug therapy in migraine patients, we always try with the non-pharmacological part first. That means trigger avoidance, exercises, and lifestyle modification. This we at least try for 3 months. And if you see that the incidence of attacks and frequency of attacks, intensity of attacks is beyond a level, then only we go in for drug therapy, for pharmacotherapy. Here also we have to maintain certain criteria. Start with one drug only. You asked me on what basis?
Yeah,
How
criteria.
no, because see, there is no specific test by which we can know for sure, no marker for vestibular migraine. So we go by asking the patient any history of migraine headaches, whether any near relatives from the father's side or from the mother's side has got a history of migraine, if there was any history of motion sickness in childhood. These are the basic questions that we ask to think that this could be migraine or not. So you need to have some evidence. Otherwise, how can you suddenly start a drug until you have some reason to suspect that this could be vestibular migraine? I believe Isha and you can also join, or anybody else from the audience. We have some neurologists also in the audience, and anybody from the audience wants to join and give in your inputs, please go ahead and
Mr. Charlie, I'll request you to unmute whosoever wants to contribute to the discussion.
Surely, sir, I'll do. So, whoever wants to unmute, they can unmute and ask the question now.
So nice. So nice of you. I will like to ask Dr. Isha. She has elaborately concluded in one case which she has presented that the patient was treated for vestibular for Meniere's disease, and then it turned out to be vestibular migraine. It has been said that if a patient of this such a complaints, he goes to a ENT person, he will be labeled as Meniere's disease. If he goes to the neurophysician, he will be labeled as a vestibular migraine. And now there is a trend that the Meniere's disease and vestibular migraine, they have got a same spectrum. They are both part of a same spectrum of the disease. I'd like to have your opinion, Dr. Isha.
Sir, what we have observed is that vestibular migraine is way more common than Meniere's. And before the diagnosis came of vestibular migraine and it became so clear cut, we were missing out on a lot of vestibular migraine cases. That one very important thing we have started doing is that not giving intratympanic gentamicin any longer. The number of intratympanic gentamicin has greatly reduced because we also read somewhere and noticed in a few patients that if we gave it to the patients who had a history of migraine, they had worsening of symptoms.
True.
So
awesome.
This is.
You have to have a definitive diagnosis of Meniere's disease and then only go ahead with the either intratympanic dexamethasone or intratympanic gentamicin.
So intratympanic dexamethasone is still preferable to gentamicin, but
gentamicin
I feel that before that anti-migraine therapy should be tried.
Very logical. It's very logical. I'll just like to ask one question to Dr. Shinal. If a person has got 2 or 3 attacks of spinning lasting for a very less time, 1 or 2 times in a week, can you label him to be a patient of vestibular migraine?
No, so like just spinning will not lead us to the diagnosis. So we'll see with other things also, like the headache part, or if he has got a hearing loss additionally, or what is this, like photophobia, phonophobia, all this we'll see. And what we do is, like, if we suspect either Meniere's disease or a vestibular migraine, I prefer doing a electrocochleography, ECG also for these patients. So like if the hearing loss is not much, the electrocochleography can tell us or in detecting the Meniere's disease also. So many times we get these patients, and if the electrocochleography turns out to be normal, I would, and other like precipitants are there or some trigger factors are there which point to vestibular migraine, we would definitely give a trial of anti-migrainous drugs. And then, like, after that, the response to the therapy, in addition to the investigation that we have done, will help us to decide whether it is, like, our diagnosis is correct or not. And accordingly, we can take a call if we at all want to change the therapy.
Dr. Rohiwal, can I just add something over here?
Yes, please go ahead.
One thing that the question, Shanal, was that if the patient is getting recurrent attacks of vertigo for a minute or so. If the patient is getting recurrent attacks of vertigo for a minute or so, then expectedly it would not be Meniere's disease, because Meniere's disease by definition, it has to be at least 15-20 minutes, more than 20 minutes, but at least 15 minutes. So in a patient who is having recurrent attacks of head spinning just for less than a minute, we have to think about other things, like it could be vestibular paroxysmia, it could have been a vestibular migraine, it could have been a vestibular seizure. These are the things which we have to think about. And then taking a history, if we can find out something by which we can shove it into the migraine system, then we'll start with a anti-migrainous therapy. And how would I choose the anti-migrainous therapy? Since I'm not very sure that it could be vestibular migraine or vestibular epilepsy also, I would choose a drug like divalproic sodium, or say sodium valproate, or topiramate, which is an anti-epileptic, anti-vertigo drug, anti-epileptic, anti-migraine drug. So see, taking all these things together, in each patient is different and we have to take a call. But in a patient who is having vertigo attacks for less than a minute, I would not first of all want to think it to be a Meniere's disease. So
yeah, please go ahead. Please go ahead, sir.
No. So that is how I think we should decide, taking everything into consideration, because the duration, the one advantage that we have in neurological practice is that each of the diseases that we deal with have got specific durations. We are constant in neurology, unlike ENT doctors. We have a big constant, like ENT doctors can do a spot diagnosis. When you're seeing a polyp, or you are seeing a vocal nodule, you are seeing an ulcer. So it is for you, your spot diagnosis is very easy. For us, for neurologists, there is no spot diagnosis. So you have to go on taking the history repeatedly, and one big help for each and every disease, each disease of neurology has got a very specific duration of attack.
Time duration.
So that helps diagnosis in a big way.
Certainly, yes. Whether the vertigo is lasting for a few seconds or minutes or for hours, that definitely gives us a clue
that will
about
give us a big lead to the diagnosis.
Probable cause for the vertigo.
I am seeing my Dr. Royal, I am seeing my teacher over here, Dr. Devna Chatterjee. I can see in the audience, wherever and whatever I am today is because of Dr. Devna Chatterjee. He has been my teacher in medical college, and so I take this opportunity to pay my personal regards to him. Okay, now let us continue.
Dr. Charu Jagtab also has logged in, sir.
Oh, great.
There. And
let him answer some questions also. Why are you
that's
pointing the questions to us? He is there.
Can ask.
He's a senior neurologist.
One question for you, sir. You mentioned about magnesium, which is used. Of course, I am also using it in vestibular migraine patients as a prophylaxis. Have you come across any time any paralytic ileus?
No, not really. Why? I did not even know that it can cause paralytic ileus. So I didn't even ask. So I have no idea that it cause paralytic ileus. I think the only one of us who has worked on magnesium in vestibular migraine is Dr. Sheni Bhatia. If she's over here, then I believe she can share.
I'd ask her question. I'd ask her this question also, because one of our patients whom I had treated, he was treated with magnesium sulfate and he had a paralytic ileus.
She had researched on magnesium in vestibular migraine.
Yeah, I know that.
Is Sheni Bhatia here? Then she can answer this.
No, she's not. She's not.
Okay, anyway.
Sir, there is one question. If a patient presents with recurrent episodes of unsteadiness without any known either autological or CNS symptoms, and in between the attacks is perfectly normal, can we consider probable diagnosis of a vestibular migraine in such cases? The problem is episodic. Person is having no autological or no CNS symptoms, but there is definite episodes of recurrent episodes of vertigo, unsteadiness, without any known pathology. Either autological or CNS symptoms are not there. And in between the attacks, the person is absolutely normal.
Who is to answer this? Difficult question.
You only can answer, sir.
No, Charu is there. I think Charu can answer. Anyway, let me just begin it. See, these episodic episodes, recurrent episodes of unsteadiness, we do get a large number of these patients. One thing that is possible is it could be episodic ataxia type 2. We have to rule that out. If there is nothing else, it can also be vestibular migraine. Vestibular migraine can also present like that. Problem is that for episodic ataxia type 2, there are other symptoms also by which you can get some evidence of cerebellar problems or all, which you may not be getting in anything else. So I would want a neurological referral also. And at the same time, you may not get in these patients, we ask for a blood test for episodic ataxia. The requisite genetic tests are to be done. But but remember one thing, that vestibular migraine can also very much present with episodes of unsteadiness. So if you don't get anything in many of these patients, empirically, without reason, we give a therapeutic trial with anti-migraine drugs also. Whether how much it is justified, it is, I believe the enlightened audience should be able to guide us on it, whether it is how much justified it is. But at the same time, a lot of these patients do respond well to drugs like this. And sometimes when not sure, I have even tried to use acetazolamide in these patients, not because of thinking it to be migraine, thinking it to be vestibular of Meniere's disease, but acetazolamide has also been found to be of some use in vestibular migraine as well as in episodic ataxia. So that is the basis on which I've tried, and I've also tried to use migraine, but then this is a little messy ground and I am not very sure about what to do. So if the audience can enlighten us on it with their experience, or if any of the speakers can tell us, it would be nice.
Ramesh sir, at the risk of sounding repetitive, I think we need to go back to the basics and go back to the history.
Yeah.
Is the patient, here the audiological symptoms are not necessary to diagnose vestibular migraine. And what exactly is meant by the CNS symptoms? We need, for example, in the first case which I showed, the patient thought that her headaches were, her neck pains were just a regular pain. Everyone has it. Secondly, are the episodic attacks occurring in a patient profile of who's an elderly who has some cardiovascular risk factors? So in those cases, I do think an MRI or an MRI is warranted. Yeah, I remember a case of a Supreme Court lawyer who had come some time ago, and he was also giving a very vague, non-specific history. So I started asking him history of migraine, and I just said that, "Are you very stressful? Do you get stressed out?" And he out and out denied, "No, I am absolutely fine. I never take any stress." And his assistant was with him, and her eyes really bugged out. So we had to send him away and take the history from his assistant and his driver, who gave us a better history. So
he must be giving stress to others.
probably, sir. So yes, so if the patient is somebody who's a hypertensive, who's elderly, and is having multiple episodes, even though at the moment you're not able to understand any.
Somebody wants to unmute himself and ask some question. Please go ahead. Dr. Charu Jagtap, you want to add something?
No. So,
Sir, I would like to ask something that if you ever get a case, and even sir, Shinal ma'am, Ramesh sir, if you ever get a case of 3PD with BPPV, I mean, I know it's slightly off topic.
No, of course we do get lots.
There are common problems.
Everybody will be getting that.
So what exactly therapy do you offer to these patients
We-
in terms of rehabilitation or in terms of
See, whenever there is a BPPV, it
medicine?
has to be corrected by the maneuvers only. But many of these patients also have something, they feel dizzy even after that the maneuver has been correctly done. So this is actually called post BPPV syndrome. And in post BPPV syndrome, which continues for about, it can continue from anything of 2 weeks to up to 3 months. They feel dizzy. So that is sometimes there where they put the patient, the treatment is to put the patient on a drug like etizolam, because that is the only drug in which they have done a RCT. Other drugs can also be given, possibly they can be tried, but the RCT is there only with etizolam in post BPPV syndrome. And post BPPV syndrome is that when you have done the maneuver and the maneuver has corrected the positional vertigo and you have checked, but yet then the patient goes on getting the feeling of dizziness. So that is pretty common, and we don't call it a PPPD. We call it a post PPPD syndrome because that's a definite disease entity, and it is treated with drugs like etizolam and vestibular physiotherapy.
So exactly what type of physiotherapy do you recommend to these patients?
Oh, see, it depends upon what type of physiotherapy. See, if we have been able to find any defect in the vestibular system, then we use a organ targeted vestibular physiotherapy. That means if there's a saccular defect, we stimulate the saccule separately. If there's a lateral canal defect or a posterior canal defect, we stimulate that separately. And also we put these patients on different types of yoga and tai chi. We have the we work in conjunction with a Tai Chi teacher also, and some of these patients we send to the Tai Chi teacher because Cawthron Cook's exercises are definitely very good, but they are now nearly 80 years old. When Cawthron Cook's exercises had come, we did not have so much knowledge on the mechanism of balance. So they were meant for the war victims only who had become imbalanced after war. So now it has been found that Tai Chi and yoga, they help in a very big way in restoring balance, and Tai Chi is very, very helpful. So we put the patient, and for general balance improvement, I believe Tai Chi and yoga are extremely, extremely helpful.
Are there any questions in chat box, Mr. Charlie?
No, sir, there are none as of now.
As of now, I can't see any questions in the chat box. Are you able to locate any question? No.
No, sir.
Okay, so I believe we have learned from each other, and I believe we can now.
I thank all the panelists for a very excellent session, which everybody, I'm sure, must be getting benefit out of all the discussion even which we had. And I thank Anirban sir for involving me in this very interesting seminar on vestibular migraine. Thank you very much, sir.
Dr.
Thank you,
Ramesh,
Alembic.
I
Yes,
believe
sir.
we must also take this opportunity to pay our regards to Dr. K.K. Desarda of Pune.
Yes, sir.
I am seeing sir is there in this thing. Sir, all our regards to you, sir, Professor Desarda.
Desarda, sir, you can unmute yourself and talk.
Okay, so I believe, Charlie, we can finish if there is nobody.
Yes, sir, we can, with a lot many comments, the comments about the entire session that's there in the comment box. And yeah, so.
Thank you, Mr. Charlie, and thanks to Alembic for making this a very educative, nice seminar possible. Thank you very much.
Thank you, sir. Thank you to the organizers and to the patient listeners.
And good night, everybody.
Thank
Good
you.
night.
Thank you.
Thank you, sir. Thank you to everyone.
Thank you. Tata. Good night.
Bye.